And one more step. We are live.
All right, William, thank you for doing that. I'll go ahead and kick us off here. I just would like to welcome everyone this evening to November's virtual Lyme impact session. We're extremely privileged to have Dr. Daniel Cameron present on a lot of the body of his work on child and adolescent Lyme disease, not only diagnosis and treatment. My name is Eric Huck. I am the president of PA Lyme Resource Network. I also run the Harrisburg, Pennsylvania support group region. And with us also is Bill Moore. Bill is on the board of PA Lyme, as well as he runs the Pittsburgh Lyme support group. So everybody's in good hands. A little bit of housekeeping right up front. As you're watching this, we're going to hold questions um, till the end. And so, as Dr. Cameron is speaking, if you have a question on Zoom, go ahead and put it in the Q&A. If you're watching us tonight on Facebook, you can add your question to the comments. We will monitor both of those, and technically, Bill will monitor both of those, and he will gather the questions, kind of organize and prioritize them to ask them of Dr. Cameron when he is done with his presentation. Just a word of caution or advice. As you ask your question, what we try to do is not get into the details of a specific situation. So our request is ask your questions in a manner that is a little more global, that is perhaps a little more identifiable with parents or viewers at large. So even though Dr. Cameron is a medical doctor, he's not your medical doctor. So when you ask your questions, just know he's not going to be able to get into specific detailed treatment for your situation. Once we're done with tonight's video, not only will the slide deck from Dr. Cameron, but also this video, the recording will be posted to palime.org. Typically, that takes us 3 to 5 days to get it up there. So just be aware that it'll be there for your viewing in the future, and you can share that obviously with individuals you know in your family or likewise. A couple of items that I'd like to bring to everyone's attention before we kick it over to Dr. Cameron. You may be aware there's been a little bit of news going around the past 3 to 5 days that there's a new federal framework for infection associated chronic conditions and illnesses. The CDC has acknowledged recently, really, what Lyme patients have been saying for decades, that these are persistent symptoms. After the Lyme infection, the symptoms are real. They're medically significant, and that they take on various combination of infection associated organ damage, autoimmune conditions, persistent unexplained systemic symptoms, debilitating fatigue, post-exertional malaise, cognitive impairment, musculoskeletal pain, and sleep disorders. So for 40 years now, Lyme patients have been saying, I still have these symptoms. What is going on? We're actually very pleased that there's now a federal guideline to take this symptomology from a chronic persistent perspective and kind of fold it into an infection associated chronic condition and illness framework. So, because of that, not really only because of that, but another item of interest is PA Lyme. We call ourselves a resource network. And between patient conferences, medical conferences, local regional support groups, we work on legislation, we work on Lyme prevention and the seminars and prevention work that we do. We do an awful lot of things that really benefit a lot of different stakeholders in the Lyme community. What we are starting to do is build some momentum to form a PA coalition of Lyme advocate groups. We are starting to form networking and relationships with other Lyme organizations in PA so that we can all learn what each other are doing, stay on top of the news, support each other. When it comes to legislation, what does that look like? So we will formally be launching something in December. This is for Lyme organizations. There's a lot of Facebook groups that are out there. There's a lot of county Lyme groups. There's a lot of municipal Lyme groups. There's a lot of one-off Lyme groups that it might be a parent or a family that's working specifically for a particular cause with Lyme disease in PA. So, in terms of financial resources, in terms of advocacy, in terms of legislation, in terms of prevention, there is really quite a community of Pennsylvania Lyme advocates. Our intention is to try to bring people together, not to be a part of PA Lyme. We don't really want folks to necessarily join PA Lyme, but we just want to have a coalition where we're working with each other to really benefit the Lyme community at large. We have a meeting in January 2026 with the Pennsylvania Department of Health officials. We're looking at, what was originally done with Act 83. What were some of the governor task force on Lyme disease initiatives? What were some of the working group initiatives? And where are we now in 2026? And what can be done from a partnership perspective, a win-win type of network partnership where we can work with our state legislator and state departments to try to, again, really support the Lyme community to the best of our abilities. As you can see there at the bottom, we've been having ongoing meeting with Pennsylvania legislators, Senator Michelle Brooks and her team, Senator Marty Flynn and his team, looking at Lyme legislation and how can we help craft legislation that is on point and that stands a good chance to make it through the Pennsylvania state legislature to be enacted and voted into law. Upcoming calendar things for you to mark for 2026. We're not going to have a December virtual Lyme impact session. It's getting too close to Christmas and the holidays, but we will have a January impact session, and that's going to be January 20th, as always, the third Tuesday of the month, and it's going to be Dr. Jennifer Platt. She's the founder of Tick-Borne Conditions United, and it's going to be on alpha-gal syndrome. And as many of you know, it is, a disease transmitted by largely the Lone Star tick, and it creates food allergy or the type of allergies that are particular to proteins, enzymes, not only in red meat, but also in some pharmaceuticals, in some food groups, medications, supplements. So it's becoming more and more of a problem. And also mark your calendars for April 18th, 2026. We're going to hold a full day patient conference. It'll be at the Sheraton Valley Forge, King of Prussia. Tickets are going to go on sale in January. We expect that it'll sell out. We have a capacity of 100 attendees. There's going to be probably 10 exhibitors there the day of. So not only can you network with 100 other Lyme patients and parents, you'll be able to talk to exhibitors to get state-of-the-art, up-to-date treatment advice, whether it is to lower the bacterial load and kill off and reduce the infection, or learning treatment advice for how to boost the immune system. So they go on sale in January. Be on the lookout. There'll be early bird discounts for the first month or two, $75. And also, the day of the conference will also be able to have ticket sales the day of if we don't sell out. So, having said all of that, we're doing a lot. PA Lyme, I always call us a ragtag group of very dedicated, committed Lyme patients. We're a very professional group. We're all volunteers. Nobody gets a salary. We're all very committed. We're Lyme patients ourselves. It takes financial resources to really work at the caliber and the level that we work at. And it's really through grants and through the good wishes of our donors that we're able to carry on and really fight the good fight for the next month. So we would appreciate it if you would consider us. I know Giving Tuesday is shortly coming up. You can preempt that by going to our website or scanning this QR code. And any dollar and all dollars are definitely appreciated. With that, I would like to introduce our speaker. Typically, what happens is, and as you know, if you've been following our virtual Lyme Impact session, you know we're getting international speakers, we're getting national speakers, we're getting highly credible Lyme experts, specialists in their particular area and the discipline of their subject matter. And typically, when we work with these doctors and we ask for a biography, sometimes it's 3 pages. What I appreciate working with Dr. Cameron, he has taken his message to the street and he has given us really bite sized, digestible opportunities to stay educated on the type of diagnosis and symptoms and treatment necessary for children and adolescents. My wife, who is really, because of my Lyme disease for the last 15 years, she's really plugged into social media. She considers Dr. Cameron to be her favorite Lyme doctor for what he's doing on Facebook and a lot of the social media that he's posting. So, Dr. Cameron is a Lyme disease specialist. He's an epidemiologist. He's the past president of the International Lyme and Associated Diseases Society, ILADS, which is our medical academic guidelines that we follow, of course. He has authored ILADS practice guidelines and an expert's guide on navigating Lyme disease. He's been around the horn, he's been around the block, he's been doing this significantly longer than I have, and we look to him for really not only the existing Lyme treatment advice based on experience, but what is also new and upcoming. Dr. Cameron continues to see patients in his Mount Kisco, New York practice. He shares his insights through his Lyme disease science blogs and social media, as I just stated. Before we got on and opened this up to all the viewers watching us tonight, I asked him if he's full bore Monday through Friday with his practice, and he said, "Yeah, full bore, full time, Monday through Friday." So for that, we appreciate what he's bringing to the table. So, Dr. Cameron, with that, want to again thank you for doing this, and let me turn it over to you, sir.
Oh, thank you, Eric, for such a gracious introduction. And I'm sure Bill will be involved shortly. So let me begin. Can you see it?
You'll have to hit share.
Oh, okay. So I gotta hit share. That must be it. Now you can?
Yes,
Good.
sir.
Perfect. Okay. So anyway, I'm going to be talking today. I got to go up a bit here. How do I go up? Let's see. Trying to figure out how to get up the page. Well, here I'll go. There it is. Okay. So I was asked to talk about child and adolescent. I do take care of adults and have been for some time. And it's been 38 years of working in Mount Kisco. So most people know me through, board member, president of ILADS, first author of those guidelines. But in the past 2 or 3 years, I kind of backed up to my private practice and started reflecting what I've been learning in my private practice. and what patients ask every day, what just routine things that I thought I'd share through social media, like the TikTok, Instagram, and YouTube Shorts, but now through this PowerPoint. So thank you for the opportunity. So we do know that pediatric cases are rising and continue to arise, and in fact, the CDC considers kids to be probably the number one group for number of EM cases that they see. There's continuing to be misdiagnosis. Schools are troubled, and with the school declines that keep coming up. And so I wanted to address why these kind of discussions matter. Now, the early assumptions with Lyme really started when Polly Murray from Lyme, Connecticut in the 70s was fighting for her child and her neighbor's children. And these cases were dismissed as juvenile rheumatoid arthritis. They didn't necessarily have a positive test, but they were treated as if they had rheumatoid arthritis, and they called it JRA. But with her advocacy, and they eventually brought it over to and fought for it at Yale, they named it Lyme arthritis. Most cases that had JRA ended up having Lyme arthritis. So at the beginning, they described things that were pretty well known and are well known now, like erythema migrans rash, the Bell's palsy. Heart block is not cardiovascular type thing or plugging, it's just electrical current. Meningitis has been hard to define, except they talked about that at the beginning. There's Lyme arthritis. They originally didn't even call it Lyme. They called it Lyme arthritis because they're rheumatologists. They're more of familiar with describing arthritis than all the neurologic things that started happening. But in 1990, and I had been in practice for 3 years, there was a paper that came out by Legigian, Kaplan, and Steer. Steer was the one who just characterized Lyme arthritis. And you see many of the things we see today were already described in 1990. Some of you in the audience, I was born, of course, but many of you in the audience may not even have been born then. They were using the word encephalopathy, which we call brain fog now. They had sensory neuropathy, that is a small fiber. Sensory system was off, and now we call it small fiber neuropathy. In that same paper, they talked about chronic fatigue, poor sleep, cardiac issues, although they weren't really referring to as POTS then. They had a lot of sensory issues. They were looking at light and sound sensitive, nausea, diarrhea. Even then, they were discussing GI issues. And then pain was described in a lot of the 27 subjects they were studying. They did call it neuropsych, but now we call it many of them PANS. So the NIH trials, and there were 3 main trials. Some improved with extended therapy, some relapsed, and some had minimal improvement. So just with intravenous Rocephin, they were getting mixed results at the time. But as far as for adolescents and children, they only enrolled adults who had been sick for years and who had failed an average of 2 treatments. So they're not talking about your average Lyme patient that you might see who's gets in a little earlier or has not had that much treatment. They also didn't include co-infections. So over time, there was the NIH has talked about these NIH trials, but they didn't talk about Babesia, Bartonella, or Ehrlichia. And there was some lip service to looking for co-infections, but they were just focusing on Lyme. And most interesting to this audience is that they didn't include children in the studies. So if you hear some doctors say, oh, I can't do treatment because the NIH studies failed treatment, well, they did have some successes, but they certainly didn't apply as well to children. So ILADS emerged as a society, and I mentioned I was president a couple times, authored their guidelines. And so what a lot of my patients and their families see is that there's a division between the Infectious Disease Society of America, where they've been granting more recently that there are persistent symptoms, but they're not infection driven. ILADS looks at persistent infection as as seen and a common part of our practice. Now, the IDSA has recently been calling it post-treatment Lyme disease syndrome for their members, but they don't mention that persistent infection is a possible reason for post-treatment Lyme disease syndrome. So you get these patients coming in and say, oh, I've got my month of doxycycline, I'm still sick, I've been sick for 6 months, but not, the doctor doesn't mention that a persistent infection, which leaves the patient lost for a long time before they realize that that persistent infection is an issue. Now, children have been, and their parents have been caught in the middle of this war between IDSA and ILADS. So I just wanted to discuss today more of the Lyme itself rather than kind of a controversy. So what the children have been caught in is that there's no NIH trials for them. There's no trials that seem to enroll kids. There's decades of stigma for kids. And of course, they get older and then they go to college if they can. Many of them actually go to college somehow. I don't know how they do it, but there's still plenty of stigma. And they hate to bring up Lyme to their doctor because their doctor is sometimes judging them. Then this impacts pediatric care today with all these years of war that have been going on. I'm just characterizing as war rather than controversy. So the second part of the three parts I'm talking about is the clinical reality and then what we must do. So Polly Murray, I mentioned, was the mother who fought for kids, fought for her neighbors, and got this going. There's also Dr. Dorothy Petruka that was early on in my career who was fighting for pediatric cases with neurologic issues. She reached out, I know, in that period of time, trying to get the CDC to look into why all these patients had neurologic issues, neuropsych issues, and they came into her office and said, well, the real problem is not Lyme, neurologic Lyme. It's that somebody has a nerve of giving neurologic Lyme cases IV Ricefin. And so they maintained to focus on complications, not on what she was fighting for. I didn't mention on this slide, but Karen Vanderhoff Forstner, she and her husband lost a child and started the Lyme Disease Foundation, which later morphed to both the Lyme Disease Association and this organization and also ILADS. And we all remember that Dr. Charles Ray Jones spent years and decades working with kids. So given they were pioneers, everyone has their own set of pioneers, but I thought I'd mention them. Now, a lot of times there's so many symptoms talked about, I thought I'd at least make up a list of the 6 most common clinical presentations I see in my practice. So a lot of times my patients and their families get dismissed as a bunch of symptoms. But these are in the literature and these are well described. And if you say, well, I have one of these, hopefully that will lead to better research on the subject. So Lyme arthritis we talked about because that's what Polly Murray was working on. Mostly swollen knees, swollen hips, SI joints, any place that has this soft tissue called synovitis. Lyme carditis was earlier identified mostly as heart block. At that time, they weren't dealing with POTS, and more recently, they're starting to talk about that. There's neuropsych issues that were talked about since the 90s, but the NIMH was studying something separate, which is PANDAS, which is pediatric, but it's associated with strep. They realized that so many people coming into PANDAS doctors were coming in because they had Lyme. So they changed the name to pediatric acute neuropsychiatric syndrome. So it seemed like neuropsychiatric issues didn't become prominent until they named it. So there's something about naming something that I think helps. So I thought I'd mention 3 different types of POTS in addition to the traditional and what we normally think is just POTS. Positional orthostatic tachycardia means it's related to position and the heart goes faster and it's a syndrome. But the literature, and then there's more specialists are looking at it as at least these 3 separate groups: neuropathic POTS, hyperadrenergic state, and hyperadrenergic state without POTS. So let me go through those because if you understand, if you say I'm just sick with everything wrong, or at some point the hope is, well, I have neuropathic POTS or I have neuroadrenergic POTS. So Lyme arthritis, that's the knee swelling with pain, can occur within 6 weeks or maybe months later. It can even occur after prior treatment. It's an effusion, so they try to culture it, but once you've had a few days of antibiotics, you can't grow spirochetes out of them anymore. And there's always this illusion that all you need is one joint, but it can be multiple joints. It can be in the hands, the thumbs, a variety of locations. Now, Lyme carditis was originally described as conduction problems, but cardiologists have jumped in and helped by calling it a POTS. Some of them have POTS, especially this tachycardia that people have later on or palpitations, is that it's defined by tachycardia increasing 30 beats per minute on standing and near fainting. And so POTS was what cardiologists jumped into. And so much of POTS has been focusing on cardiac issues. Actually, POTS is a lot more sophisticated than that. So there was a cardiologist from Texas who once said POTS has many types. And so I'm just focusing on three types of POTS that are talked about. But just before I get to POTS, I wanted to mention PANS again. This is I think people understand PANS better than just neuropsychiatric issues. And that's where you have a broader perspective than if it was defined by the National Institute of Mental Health. There they describe it as tics, Tourette's, and OCD, but they didn't include all these other symptoms because often they're seen in so many illnesses. But if you have PANS, there's often anxiety, emotional lability, irritability, aggression. Pretty much every emotion you can think of can turn up. I usually call it waves because they don't have to be there all the time, but they're still pretty disruptive if you got a wave of irritability or Lyme rage. If you have a OCD type rage, there's despair. Dr. Bransfield talks about suicidal feelings, aggression feelings, and but does lead to developmental regression that shows up in a lot of kids. So a lot of schools have to deal with these kind of performance issues in school. Also, some of them have troubles with, especially with athletic issues, standing up, participating in sports. They're getting behind on their goals and dreams of being involved in the sports, or it also, if it's an adolescent, in their dreams of trying to get a good resume, good grades. And it leads to all kinds of somatic issues like sleep issues, urinary symptoms, and handwriting. So let me go back to the three POTS. Remember, for a second, I diverged to the PANS. There's three types of POTS I'm focusing on today. It seemed like it's much of these POTS are all related to the fight or flight, the adrenergic nervous system. So this neuropathic is more of a kind of a reduction in that fight or flight. So they become more like a small fiber neuropathy. There's some autonomic nervous inflammation. There's some vasorestriction. So sometimes the blood pools in the legs turn bluish or a reddish tint. There can be pulse spikes. And so I don't actually see very many neuropathic POTS patients over time, but I see them once in a while. And it's small fiber neuropathy where you have to biopsy or do some work on the legs trying to see if you should do IVIG. But because it can occur in Lyme sometimes, I always tell people at least leave a persistent Lyme infection as a thought. This is more of the POTS that you see in practice. You know, the POTS where you stand up, it's cardiovascular driven. It's a sympathetic system with adrenergic, but it leads to heart rate and blood pressure, but essentially it can lead to surges when you move. It's part of the autonomic nervous system. So when we say dysautonomic, means there's something wrong with the autonomic nervous system. I want to spend most of my time on the clinical side of something that I see in practice so much. Remember, I talked about traditional POTS, traditional PANS, the neuropathic PAN, but this one is it's hyperadrenergic, fight or flight without POTS. Because your POTS implies that you get up and do something and you feel sick, and then you go lie down, it's not so bad. But so many of my patients actually are feeling crappy in bed, crappy in the sofa, crappy in the kitchen, crappy in the car, even if they're not doing much. And so it's still excessive sympathetic adrenergic but you don't always have to have a heart or blood pressure change. And so sometimes I go to cardiologists and they'll say, well, you can't have POTS because you don't have blood pressure pulse changes that meet the definition. Your tilt table is normal. But this still occurs when norepinephrine is up you get still surges of adrenaline. That's why you often see patients, or I see them in my practice, where symptoms come on like a wave or like a tsunami, and they can be rare, bad enough as it is, and then it goes up and down. Every time it goes down, then there's dread of it. It's going to go down and then up again, and so it happens even without the Herxheimer reaction. People tend to say, well, it occurs even when I'm not taking antibiotic. So they use the word Herx because it's pretty descriptive. There's tremors, palpitations, rushes, and the heart rate doesn't really have to go up. So I thought I'd go into some of the different types of hydroadrenergic state where you don't have to have POTS. This is probably something I use in my practice all the time with kids, is that uh, so many of them have these without necessarily the focus on POTS. Some of them, yes, indeed, have heart racing, blood pressure spikes, pounding, heartbeat. That's kind of a POTS part. But many of them have, with this hyperadrenergic state, have like internal vibrations, tremors, head pressure. A lot of times I have patients that have pressure here, or pain right behind the eyes. Nothing wrong with their CAT scan of their head, nothing wrong with ear, nose, and throat. So that head pressure is sometimes what's the cause of their pain. The sensory system is turned up with this adrenaline, so they can be sensitive to light and sound and heat and cold, or at least 3 out of 4 of those. Then the brain fog, even when it worsens when they're standing, but they can have when they're not having a surge without standing. Now, because the gut's part of the autonomic nervous system, it can be labeled irritable bowel, gastroparesis, leaky gut, but essentially autonomic determines bloating after meals, slow digestion, nausea, early fullness. But I think constipation is probably one of the unusual ones because it's so common. There's a respiratory as part of the adrenergic, so there's air hunger. We often do that, refer to babesia as the cause of the air hunger, but air hunger seems to show up if you're particularly sick anyway. And then there's a sense of shallow or deregulated breathing, even when you're not being very active. In fact, more often when you're not doing much of anything, the urologic system you might see frequent urination, urgency, pretty much everything that's automatic that you don't have control over. At the skin, you can have excessive sweating, which we often say is babesia, but if you're particularly sick, that'll still be involved in other tick-borne illnesses. And then the whole sensory system is involved. So people are sensitive to light and sound, heat, and cold. And sleep is with the adrenaline, the surges. Early morning adrenaline, people have trouble falling asleep, staying asleep. They wake up exhausted. So if I were to go through those symptoms, often those are symptoms that bother my kids more than anybody, rather than just POTS, because they're not often doing a lot of stuff and they're just as sick and it changes. And I refer to on a 1 to 10 scale, they're kind of like maybe 7, which is crappy, but very quickly they can go to 8 or 9, which is crappier, and 10, which is the crappiest. So they keep going from 10 to 7. They're better. They feel somewhat better, but they're still crappy. Now, this is not a new term. It's in the literature. There's many names being used, and so there's no universal accepted name. Some people refer to it as hyperadrenergic state, then adrenergic overdrive, sympathetic overactivity because of the fight or flight, autonomic storming. Because in COVID there's storming also. I think it's an issue that's a possibility. Then there's a baroreflex dysfunction, like with the vagus nerves, the autonomic nervous system dysfunction, adrenergic dominant. Then there's pre-POTS, where you're not really in POTS yet, you're hyperadrenergic. I like the one I wrote out called autonomic regulation disorder. So instead of saying I suffer from a bunch of symptoms, one can say, no, I suffer from autonomic regulation disorder. That might get further than just saying you got a mess of symptoms. And also, I find that type of discussion with my kids, let them understand how come symptoms are so severe, how come there's so many problems with that they're suffering with, whether they move or don't move. And if they go to a cardiologist, sometimes they'll get treatment for the vascular part, but the various treatment for it aren't going to help these symptoms very much. Yet they might be able to sit up better, but that's about it. We need something that's a little more effective, but calling it something and saying I suffer from this might make it easier to be accepted by the medical establishment or even patients communicating with each other, parent communicating what's going on. Because I think a lot of doctors now know about pots and pans, but not about this hyperadrenergic state. The challenges to discussion or to diagnosis is that if you get labeled as another condition like a psych condition or fibromyalgia, or there you run into like doctors tend to not change from what's already in the chart. Parents say, "Oh, I have this," and then another parent says, "No, I have that," and then a kid says, "Well, I have that." And so there's a kind of reluctance for people to change their diagnosis, even consider Lyme. So I run into a lot of discussion of that. I spent time on getting people to realize that at least Lyme is a possibility. The tests aren't so reliable. A lot of doctors and a lot of families are reluctant to do anything unless the test is positive. Co-infections don't always get ordered. There's something called clinical judgment, where if the test is negative, the doctor still has to decide if they're going to treat or not treat. So they're both clinical judgment. If the doctor says, "Oh, I'm not going to treat because your test is not positive," that's a clinical judgment. Just like I might say, "Well, there's possibly a persistent infection here." And also, if you have two diseases, let's say if you already have a seizure disorder, ADHD, migraines, depression, how are you going to recognize Lyme if they already have an underlying illness? You're not going to get rid of ADHD just by treating the Lyme. So I have to tease out with them is what's ADHD symptoms, what's seizure issues, what's autism, and so because you'd hate to have an autistic person. I've had them before where people didn't recognize that the Lyme was part of their story. You just want them to feel better. And the testing is a problem, and many of you have heard this already, is that the ELISA, which looks at the outer surface protein C, I believe, is that it's often negative. The Western blot was adopted in 1994 and hasn't changed. And it's used by the CDC, but it's maybe a third. You pick up about a third of the cases when you look at the IgG type. So it's not too good if that's all you rely on. The PCR is nice, but you rarely ever get a positive test. The spinal fluid is only um, 2 out of 27 had a positive spinal tap in that 1990 paper, so it rarely ever shows anything. Seronegative is common where the tests just don't support you. Plus, the false positives are always an issue. Is that especially when you say, "Well, I got two bands, two Western blot bands," and that can come from healthy bacteria or it can come from Lyme. So you're always trying to keep them kind of in mind that any positives, the mycoplasma is positive in healthy people, and so you're trying to figure out if they mean anything. The Epstein-Barr is positive in so many people, most people by the time they get to be an adult, but does that have anything to do with it? So there's always that discussion. But really important for kids is that they don't have a test yet to tell you when Lyme is over or any of the co-infections are over. So I have parents come in all the time saying, "Let's retest to see if it's gone." The band might disappear, but that doesn't mean that the Lyme is gone. I use these quite often, and there's other ones around and other ones to explore, but this first group, doxycycline, minocycline, and tetracycline, are related. And there's quite a few in the penicillin family, like amoxicillin, cefuroxime, which is ceftin, ceftonir, which is Omnicef, penicillin, and IV Rocephin is also, which is IV ceftriaxone, is in that same family. Zithromycin and Bioxin, which is called clarithromycin. There's two drugs that commonly got introduced because they work for Bartonella in cat scratch fever, rifampin and Bactrim. And lastly, on that piece of paper is that on the slide is that atovaquone, which is marketed as Mepron, which is a liquid, 750 milligrams, and the Malarone is a pill. I've used both quite a bit, and those are for babesia. I tend to use Malarone more often because it's a pill rather than liquid. lower dose, but that people tolerate them much better. I even have a pediatric dose of Malaron, which is helps prevent some of the Herxheimer reactions that people have. So there's a growing amount of information on why some people fail, why some people are tough to treat, why you might need to use more than one antibiotic. And so the biofilm where spirochete might hide, the round body is what they form when they start getting treated. And then there's the persister cells where you don't get really resistant bacteria. You don't get resistant Lyme. They just aren't moving much. And so they're not moving, and therefore you're hard to kill them. So perhaps 10% hang around, and you have to treat a lot longer than expect, even if somebody's better. So I'm not going to dwell on those mechanisms other than there's bound to be more mechanisms that are around. So this third part I want to discuss is what we have to do. What's ahead is that we need to sort of acknowledge that there's a lot of symptoms, but that they're actually often particular names to it, like dysautonomia, POTS, sensory hypersensitivity. There's rage, panic, OCD-like, cognitive decline. So I didn't have a complete list, but I think it's better to name them rather than just say a bunch of symptoms. And you need trained physicians to recognize the non-classical, that is the early presentations. So some examples are autonomic dysfunction, neuropsych, GI dysmotility, and pediatric mood shifts. So GI dysmotility might be lumped into the hyperadrenergic non-POTS type. And we need to move for more reliable tests because a two-tier is only about a third sensitive. I mean, two-thirds won't have that criteria. Now, sometimes people can go to reference labs and find more bands or more markers. And so we're still, even with the best of labs, we're still having troubles, especially when the medicine tends to lean toward a positive test. Medicine itself has a problem because there are a lot of important diseases that have no tests. Like migraine, there's no blood test for that. For chronic fatigue, there's no blood test. Fibromyalgia is just pressing on different parts of your body. And so it's almost like Lyme is at a disadvantage because by having a test, people think a test should be good, should be accurate. If anything, things are a problem because those tests are just there but not reliable. I should mention ANA, which is a lupus test. That's kind of the opposite extreme, which is so many people have an ANA test but don't have lupus. So there you get so many false positives. I keep sending people to rheumatologists, and there aren't very many lupus cases out there, but there's a lot of ANA cases. So what I do is I treat individually. I don't pick doxycycline for everybody. I should mention, since this is an adolescent and child, focus is that they keep lowering the age of which you can take doxycycline. So it used to be like 12, 11, and I think it's down to 8 now that you can safely take it without dental changes and affecting the bones. But the CDC has said that they really haven't seen any problems with doxycycline if you take it up to 2 weeks, no matter what age. And because they use a lot for tick, well, not tick-borne, Rocky Mountain spotted fever, and that's where they use doxycycline for 2 weeks. So if I have Ehrlichia or anaplasmosis, I might have to use some doxycycline or a backup rifampin. But normally with kids, if I have to go past 2 weeks, especially under 8, I might have to move to some of those other drugs. But we need to learn more like tailored antibiotic selection to the syndromes that I'm talking about today. How to deal with co-infections. Should you always start with Bartonella first? Should you always start with 2 antibiotics at once? Should you ignore Babesia? Because I have a lot of doctors who focus so much on Bartonella, they never get around to looking at Babesia. Or they don't look at amoxicillin family because they're focusing on Bartonella. We need to get better understanding of the neuroinflammatory and autonomic stabilization and how to support the gut because you're taking an antibiotic and yet the gut's affected by the autonomic nervous system. We need to address co-infections more aggressively. I think we should treat Babesia a little sooner like at the onset if it turns out that there's any suspicion because doxycycline doesn't work for it. You can build treatment protocols for not just a single pathogen, but as I mentioned, Babesia and Lyme. That would be something like doxycycline and pediatric Malarone. So the last two slides, sorry if I go faster today, but we'll have a question and answer. But I think this is an extremely important slide, which is to protect patients from medical abandonment, is that we need to stop dismissing patients whose tests are negative. Because, I'm in a room and if the child hears that, oh yeah, your tests are negative, you don't have any evidence on Lyme, and they get turned off pretty quickly. The father or mother, one of them gets dismissed, and they're often lost to follow-up for months to years. We need to take chronic symptoms more seriously, that you can be chronically sick trying to get through school, trying to get through college, and we need to take it more seriously instead of abandoning the patient. Mental health, oftentimes I have kids that are told they have mental health problems, not Lyme, but it's still important to address their mental health needs because it's pretty tough to be a kid with waves of fatigue and coupled with the anxiety, rage, all kinds of things. And so, how do you get better mental health support for people who have psych as part of the issues? I have kids who don't talk about their psych issues much because they're afraid they'll get labeled and they won't get treated because they'll say, "Oh, off to the psychiatrist." And or a doctor who's not a psychiatrist, who's not trained in psychiatry, says, "Oh, that's a psych issue," and then you get right in the chart that it's a psych issue, and they end up getting lost to the system. And then teaching clinicians how to validate that they're sick, not alienate, would be a quite useful. And what's important in not only this illness, any illness, is that the caregiver, the family, need a lot of support. Grandparents, because they're often overlooked. The patient is suffering, but they're also suffering. The brother is having troubles. The sisters, the siblings, and so it's how do you deal with the fact that it's a pretty complicated disease, and if it's there a long time, those parents and their families need support. And also, I mentioned the crisis line for suicide is that Dr. Bransfield talks about it, but he says they usually don't have a plan; they just have the feeling. But it's still important that if somebody has that, to at least use the services that are available to look into it. So we went through a lot of material, but I wanted to share with you what I see in my practice because instead of writing guidelines, working with ILADs, looking at the choir over there, I thought I'd turn around and spend time sharing what I see in my practice. Not that I got it all figured out, but what I see, I have a better sense of what the issues and challenges are that we all face if we're a professional, but also if we're patients and the family. So I appreciate the opportunity to spend some time on this all important issue that I see in my practice. So thank you.
Thanks, Dr. Cameron. We're starting to get some questions come in. If anybody has questions, you can use the Q&A feature here in Zoom, or if you're on Facebook, just want to leave a comment. We have a question that came in early on, Dr. Cameron. Is there a test that a person can confirm chronic Lyme after they've had massive amounts of antibiotic treatment, including IV antibiotics?
Well, many of them don't get positive tests in the first place, and that's frustrating. Or even if early Lyme, they may never get a positive. That's why we tell them to get treated for an EM rash anyway, or swollen, so even considering Lyme for swollen joints. But there isn't so clear. A lot of those positive tests stay positive even when someone's well. And sometimes with antibiotics, they'll drop, but it's not very helpful to do tests to judge where they're at. But it's still worth testing. A third of the time you'll get something.
Okay, thank you. I have a question about gut health. When it comes to gut support with Lyme, is there anything that you recommend?
Well, oftentimes the gut is underappreciated anyway. There's so many papers written that, oh, the gut's spared. There's no problem with the gut. So therefore, a lot of people go off and work with the gut to a gastroenterologist, to a or somebody in functional medicine with gut issues. But because if gut's recognized as an adrenergic part of Lyme, I find that if I'm more cautious with their gut, use a pediatric dose of it, to use probiotics, try to stay away from alcohol and sugar. Alcohol is not as big an issue in kids, but all those things, I try to get the gut to cooperate. And even the pediatric doses of Malarone, which is 62.5, or doxycycline 50, or 25, if they're really young, is better tolerated. And so I might still, rely on others who work with the gut, but I'm not afraid of the gut. I have some people who are taking on the approach that Herx is bad. You can't take antibiotics. You should stay away from antibiotics, and amazing months and years pass before they'll dip their feet back and try to take on Lyme disease. But it's important in Lyme, important to keep the gut going.
All right, thank you. Next question. This person is a volunteer and they give presentations on Lyme and tick-borne diseases, and often the topic of kids developing ADHD after Lyme comes up. This person wants to know your thoughts on what kind of information can they share about ADHD becoming worse after Lyme.
Well, the ADHD, there's kids that come in with ADHD already. The only reason they might look at Lyme is because their ADHD medicines isn't working anymore, and they have all kinds of other issues that aren't um, explained by their ADHD story. I think that the with families where you always have a tendency to pick one diagnosis, stick with it. It's pretty hard to deal with the nuances of overlapping symptoms like that. Oh, and also with the ADHD medicines, with Lyme, even if they say, well, maybe that's ADHD, let's take medicines for that, is that they don't tend to work so much as in Lyme patients because it makes them more awake, perhaps, but they don't concentrate much better. Their brain fog is off. They just don't have the value they see, and that goes with all of those stimulants.
All right, thank you. Someone has a question about IVIG. What are your thoughts on using IVIG for long-term patients?
Well, there's more than one path to get there. So I have patients who come in with the IVIG path first, because I told you earlier in the presentation that uh, axonal sensory neuropathy, which means the nerve is not quite good, that's been identified in 1990. That evolved into small fiber neuropathy where you might have to do a biopsy or special tests. So there's some people have IVIG and get some value out of it, but I've found I'd rather not overlook Lyme and give it a chance first. They might add IVIG later. So I think it's just more of two paths, and figuring out which one works for the person. But since IVIG is expensive, it's IV. Sometimes it's like 30 grand a month, 25 grand a month,
Oh,
unless it's covered. Whereas Lyme, in terms of cost, is that I don't pursue IV that often because it's pretty pricey. Plus, you got to put a PICC line in the arm or a needle, and so often the pills are generic and so often effective. And also, like Babesia that I talked about, there is no IV for Babesia. It's a generic drug, and so cost-wise, I'd rather start with antibiotic. But I can understand if somebody gets better with IVIG, that's a blessing.
okay, thank you. Next question is about mold. Why do patients with Lyme also test positive for mold toxicity?
Well, I think that whenever somebody's sick, I'm an epidemiologist, so there's with this whole chain of events that occur with this kind of illness, if you check for mold, if you check for mast cell, if you check for autonomic nervous system, is that there's multiple things wrong. So some people pick the mold as their strategy. I find that the tests are positive In so many patients, they have to figure out how many false positives, true positives. But the biggest thing, as I tell people, instead of worrying about mold or Lyme, is that I have Lyme patients where if you get them under control, then they might still test positive for mold, but at least their mold symptoms have dropped. But others will pick the mold first. In fact, I have some people that like mold enough that they're counseled not to take antibiotics because they say, well, stick with mold, work with mold, and don't take an antibiotic because you might get a Herxheimer reaction. So I don't like to go that extreme, but I have patients who do the opposite. They'll do mold at the same time as what I do.
All right, thank you. The next question is, if rounds of antibiotics didn't help, what is the next step to healing?
Well, sometimes if one is still looking at a persistent infection, sometimes change to a different antibiotic might work or a combination. Like, for example, babesia is my most common co-infection that's overlooked because, they've taken doxycycline, they've taken amoxicillin, zithromax, but forgot that babesia is a parasite. But I have people fail just like people fail with mold or fail with mast cell. We all have some failures. If somebody has some modest gains and then relapse, then I have something to work with. But yeah, I certainly, as much as I'm talking about today, is that I get my share of failures or people who are, half better, two-thirds better, and they're seeing me 6 months later and they're still working.
All right, thank you. This next question is about insurance. Have you had any experience with insurance company denials or prior authorization asks on extended antibiotic claims?
I haven't had problems with the pills, the oral, because they're pretty much all generic. The only exception is sometimes that Babesia is considered a travel medicine. They use travel medicine, so they might not get covered. But with GoodRx, it's maybe $80 a month. I don't tend to order a endless amount of tests. It's just because I'd rather use the resources on treatment. So because there's I have patients on a budget, quite a few people on a budget where I'm making choices between an expensive test or there's some interventions that are rather pricey. And so I guess where I might get denials is if I do IV. That's where I get some denials, but I don't do IV as much. But if you're sick enough and you end up with IV, there's a fair amount of resistance from insurance companies for intravenous antibiotics. And if I'm going to use intravenous, I tend to use the Rocephin. I don't tend to use I don't use Zithromax IV or doxycycline IV because they come in an oral form. And so I prefer to save my resources if I'm going to do IV to IV Rocephin. Am I going through the questions too fast? Because I'm making Bill work hard trying to keep up with my questions. You getting them
No,
all?
no, this is good. Yeah.
Okay.
The next question is fairly specific. I want to try to generalize it a bit. This person was extremely ill in 2016 with chronic Lyme and saw you, Dr. Cameron, switched to a closer doctor, lots of hills and valleys. This person hasn't been treating since 2023 and not doing well. Seeing a new family doctor put back on doxy, testing shows co-infections and wondering how to proceed. I think the bottom line question is, do I go back to full treatment?
Well, I
That's
think
pretty.
that, well, certainly I have people who come back to me after a while, having tried other strategies. Most important thing is whether I'm seeing them or not, if it drags out, is that I have to keep adding layers of specialists just to make sure I don't miss another disease, that another disease hasn't emerged. See if often see a neurologist, rheumatologist, cardiologist, ophthalmologist, um, to try to make sure I'm not missing anything. I should mention eyes because I didn't mention eyes today. Is that there's a fair amount of problems with eyes that aren't measurable with an eye exam. Like they might have distorted vision the way they look at things. It's look around and something's wrong. Dr. Padula discusses that a lot. There's dry eyes. There's a sense of discomfort, I said, behind the eyes. And so there's a lot of things wrong with the eye that you can't see. There's dark spots, or no, white spots, no, spots that they see. And so there's a lot going on. But back to what you had, we'll go back to your questions.
All right, this next question is about when you have positive POTS and Lyme IgG only
Yeah.
and or antibodies to Bartonella, not IgM, do you still treat with antibiotics?
Well, if they have IgM, most infections they'll morph to IgG. IgG is more of an advanced look at the infection, but for some reason, Lyme, you can't count on going from M to a G. So a lot of doctors will say, "Oh, you didn't get a G, that's it, you don't have it." But that's because they're focused a little too much on the test. They forget to look past the tests and grousing about the tests, and you need more of a clinical history and ruling out other infections. But no, I definitely treat IgM patients who never get IgG, but I have to use clinical judgment. I don't want to be treating somebody based purely on IgG. Sorry, I don't want to base purely on IgM. That's not what I do. Even G, I have to be careful, but M is it's a patient, not the test.
Okay, this next question is actually two questions, so let me ask it as two questions. First question is, what is POTS?
POTS is in this case, I'm talking about it in a broader perspective that the whole adrenergic system is off. POTS is just one type of the adrenergic where it's defined by cardiologists as their blood pressure and pulse changes. The person doesn't feel blood pressure and pulse too often. Mostly they just feel like the lightheadedness, the dizziness, the weakness, especially if they're trying to be an athlete. In fact, kids have a lot more POTS problems than adults. For some reason, maybe their adrenergic nervous system is more dynamic. So, but they'll often be knocked out. Adults might have it, but they can usually function. So its POTS is partly narrowed down to a little shorter definition because cardiologists were the first one to put a name to it. And it's also objective. You can measure it.
Okay, the next part of this question is, can you test positive for Lyme for 5 years and then blood tests show up negative twice, 6 months apart?
Yeah, well, it varies between labs, varies between what test is ordered. Sometimes I'll order an ELISA, sometimes a PCR. Sometimes they'll order an ELISA, but it doesn't do the Western blot. So, or it could be that it's just actually gone. That if you use the same test, same lab, same technique, they could go back to normal. But that doesn't mean that my child is well. It just means the test is normal. I still have to use clinical judgment. When people get better, and there's certainly a lot of people who get better, walk away with positive tests, walk away with negative. And like even today, I had somebody, and because I've been around so long, this one came in just because I took care of him, but now he's bringing his son, his teenager, in. So be surprised how often when you've been around that long to get children of children. So I guess teachers have the same thing. These old teachers out there get their kids. I did the same thing for me. They may be well that many years, 20, 30 years later, they're feeling well, but they recognize it in their child.
All right, next question. What do you treat first, the Lyme or the anxiety and depression, which has worsened from all the illness symptoms?
Well, I do both. Instead of spending all my time on ordering tests or procedures, all those other things, I spend probably half my time engaging the child or their parents into how beat up they've been, how roughed up, how disappointed, all these other things. And so the antibiotics don't become near the center of the focus as trying to get a healing process going. Now, not every doctor has that style. That just happens to work for me.
All right, thank you. What is your opinion on excessive EMF exposure in chronically ill Lyme patients? Does that contribute to illness, and what avoidance strategies would you recommend?
Well, I'm not sure it's easy to get away from it. It's just that I don't know the field well enough to to talk on preventive strategies. What percentage the role is it? I always find that there's multiple ways of being stressed and having the immune system take off. As we talked about earlier, mold might do something, stress, the anniversary of something last year, even concussion. If you get a concussion and are taking a TBI and it's dragging on too long, I've had patients where uh, there's too much focus on the concussion, they forget that Lyme is underneath it in the background, that all the concussion did was just push the buttons. But there's a lot of things that push the button. Sometimes it's it it's the weather, but it could also be because they're having excessive sugar and it just gets them into a fight or flight adrenaline overdrive and they have troubles. Things that sometimes they're too active. They got two or three things in a row. In adults, I see this if they have 3-day wedding, it's hard to sustain full activity for 3 days in a row because they can't go from full activity to sleep very readily. So then if they have to get up in the morning, and I think that happens with kids sometimes. They're so booked up and they've cut back, cut back, cut back. But as soon as they do something in the evening with the family, they just can't turn that adrenaline off and make the transition to sleep and get to school the next day like they would when they were younger.
Dr.
Eric, I
Cameron,
know, I'm sorry.
I received a question. You had made the comment about just the observation of someone that may have had Lyme, a parent, for many years, and then years later they notice the symptoms in a child. Can you speak a little to congenital Lyme?
Well, I haven't been taking care of younger kids, so it's all I know is that younger kids get exposed, they get tick bites, their parents can get tick during the pregnancy. The challenge is they don't have any great blood tests for knowing what's acquired as an adult, as a kid, and what isn't. So that's why there's a lot of gestational Lyme that's talked about, but it hasn't gotten very far. Jones used to talk about it a lot, but it's hard to do the work to see how often it occurs. Because I take care of more of a tweens and teens, is that I'm not going to see a way, and plus I'm an epidemiologist. I tend to look for data as best I can. And so I haven't really been doing much in that area if I don't take care of those kids. I do, keeping that in mind, is that when somebody gets Lyme, could be all the way back to childhood or during pregnancy, could be. But I have this, no matter how many things I try to see, whether it's a tick, it's a rash, or this and that, ultimately I have to take care of my patient that's 17 right now, today, instead of spending too much time on who done it, when was it done, is how do I get them better from today instead of focusing on the perfect story.
We got one more question. Would improving immune system help suppress Lyme over time?
If you say it again, improving.
It's basically a question about improving your immune system.
Oh, well,
If you work on improving your immune system, would that help suppress the Lyme?
there's more than one way to work on Lyme. So I tell people to at least try to eat differently, stay away from processed sugar, stay away from alcohol, stay fit because it's so easy to sort of you're so sick to get back to nothing or couch or bed, and so how do you do something there to get back to being more active, more engaged with people? But doing it ahead of time before they even get sick at all with Lyme is still probably just being as healthy as you can, engaged with people, take on the world, and other than that, I don't think there's that too much than just being healthy. Because there's a lot of people that get Lyme, but there's plenty that don't. So I'm always getting brand newbies every year of people who thought they were fine. They were fine, the parents were fine, but out of nowhere, a newbie is comes down with Lyme. So it's often, I should mention, it's often choppy. When somebody gets sick, then they get better. They go from up to 10 or 9 and back to 6 and up and down, and they go back and forth so much that they lose track of what normal is. By the time they come in, they often don't come in because they recognize it. They come in because someone at Thanksgiving recognized it. or someone that hadn't seen them for a while said, gosh, you're sick, and has to figure out how to get them to be aware of how sick they are. It's hard to believe, like, how can somebody be that sick and be oblivious to the fact that they are that sick? So I have to do a lot of counseling with new families and new patients to get them to understand the extent of the illness. I should add, though, is that the audience that you probably have on uh, this video is that I'm talking more to people that are more on the newbie end or have been sick for 3, 4 years, 10 years. There's always a group that's failed everything on the planet, or it seems so, that they still run into other people who are still not so sick, and so it's still a challenge. It's just that I'm not implying that everybody I see is well. I'm just a fighter for all of those who are lost in the system, or getting started in the system, or get discouraged in the system, and or struggling with ups and downs and flare-ups. And my patients have a lot of the same challenges anybody else does. It's just that I'm breaking up into pearls that I see in my practice.
Dr. Cameron, there's a question about a blood test from T-Lab. I'm not sure if you're familiar with that. Have you heard of T-Lab, and do you have an opinion on their blood test?
Um, well, I'm in a strange state. Like New York is the only state in the country where you can't order as many tests because the state requires an extra layer of certification. So some of these special labs I can't actually do straight up. I see the results sometimes, but because I can't do it on a regular basis, I'm not the best judge of reliability, sensitivity, specificity. So I'm not a best source on answering that kind of question. So
Here's a
Bill, are there any
question.
other questions?
Well, no, there's a couple more coming in.
Okay.
Here's a question about what's the best treatment for late stage Lyme: antibiotics, herbs, or homeopathy?
Well, I'm biased because I'm more of giving antibiotic a chance first. But I have plenty of people that come in where the like homeopathy wasn't enough, but I only see the ones where it wasn't enough. If homeopathy worked, why would they come see me? I only see some of these other treatments that are out there, and only get involved in those who aren't getting their health back. I'm also an advocate of giving the infection a chance first instead of just working on the autonomic nervous system through alternative medicines. So that works for me. So that's why I thought I'd share that perspective. I know I have people that have been sitting on that with no antibiotics for a year, 2 years, 5 years, and it had never occurred to them that maybe they should take on the Lyme directly.
Okay, we have another question. I'm going to break it into two questions. What is the best remedy for a Herx?
Well, Herx is an abbreviation for Herxheimer, which is the syphilis specialist who Derek Herxheimer realized that people get worse when they break up syphilis. Now, people here in your audience, probably not many of them have to face syphilis, they but Herxheimer is just it seems like an immune response to the breakup of the either spirochete, and but it's still it's still working on that. It's just that it's a flare up once you start treatment. But because my patients get the same flare up when they're not even close to starting an antibiotic, they're not even starting an antibiotic yet, is that they use that word Herx because it's not really very descriptive to say, oh yeah, I had a flare up today, and you're thinking, oh great. Or if you talk to your friend who has Lyme and say, I flared up today, and but instead like Herx is like a really descriptive word. And so because it occurs, I often talk to them first about it. I often, if they're having stomach troubles or pretty really sick or sweaty, I might start with one drug instead of two. And I might lower the dose, like I mentioned earlier with Malarone. Even though there's discussion of taking two medicines with Bartonella, I often start with one just to stay ahead of the game. And to be surprised at how many people tolerate Herx even though they don't like it. But you can get herx even if you're not even taking an antibiotic. So it's hard to ever say, "Gosh, I'm not going to get herx." But it's scary when one has a flare up of symptoms, whether it's from an antibiotic or not. And then they get like a post-traumatic stress disorder type feeling. It's not officially a PTSD type situation, but anytime someone has a flare up, whether it's antibiotic driven or not, it's I often have to incorporate that into my next visit to discuss what it's like to flare up that often, that severe, and lose everything, several times a day. So I don't think I could avoid it, but management is all I can do. Once they start getting better, they usually hurts less. So it's sort of probably better to sign of improvement is saying, "Oh, I didn't hurts yesterday, or I got through a whole weekend and hurts." I had somebody today that was realized they were getting better because they were able to have Shake Shack, Shake, whatever that burger is. They were able to get through a burger, and there's not even that much sugar in there. But I don't know. So it's weird how trying to walk people through these kind of tough times.
Okay, the second part of the question is, can I still have persistent Lyme after IV treatment?
Well, IV treatment only works for Lyme that we know of. Um, we learn about cat scratch fever where you have Bartonella. So most of what I know about what to do for Bartonella is from cat scratch fever treatments. But typically IV isn't isn't on the list of treatments for Bartonella. So it's a IV also doesn't work. IV Rocephin doesn't work for Babesia either. In fact, there's no intravenous for Babesia. So it's a intravenous. I've had people go to doctors that say, "Oh, you had intravenous Rocephin, therefore it's hopeless because you're still sick. You shouldn't do anything more. You've had the best. You've had the best they have to offer, and don't even bother." And so and then they come into me 2 years later, and we're under the belief that a failure of IV means you're failing and you're not going to get anywhere from any other antibiotics.
Bill, allow me to ask one last question that I've got here, and then I'd like to go to a share screen. Um, One of the parents texted me and wants to know if you have any guidance in working with their child's teacher and school nurses. The child is apparently in first grade.
Well, I don't take care of first graders, but I have a lot of communications with teachers and or counselors, but especially teachers the most because there's all kinds of things available. There's more. It used to be years ago there nobody understood Lyme in the schools very well at least. But now they're well aware of Lyme as a group. That means they're well aware of these kind of chronic illnesses. So I regularly have to work with them to try to figure out how to achieve what they're hoping for educationally. I also be surprised how many kids are so sick, somehow they're making it through the school. Sometimes they have to use home instruction, sometimes a combination. But if I was that sick, I'd be under the table. But for some reason, that we get through the spring, get there, finish up, and get to move to the next grade. Be surprised how many people end up in finishing high school after all. College. That I was in Washington a couple of years ago where a grandma came up to me right away and said, "Oh, I think you're Dr. Cameron," but their kid who was on IV and couldn't go to school was um, was able to go to college, finish her nursing degree, and was married and had two kids, and so they hadn't had a recurrence since, and so they were, there's a lot of successes out there. So that's probably what I encourage professionals to work in the field, come into the field, and is that it's a challenge. It can be a challenge, but it's so rewarding to take the kinds of kids and parents and brothers and sisters along to successes. So, sometimes it seems like there's nobody getting better anywhere on the internet. But as I write on social media and do videos and things like that, you'd be surprised how it's a safer zone for people to share when they are getting better. That doesn't say that there aren't plenty that aren't, but that those who do well, the algorithms don't really reward people who are doing well. Um, but they are so many of them are doing well that I thought I'd share some of the pearls of things that I do to move over to the success category. 'Cause I
That's
certainly have
great.
failures too. I just didn't focus on just on how sick somebody can be and how they're failing everything and this and that. Says I have those that I have to try to get out of that hole.
Dr. Cameron, can you take your slide deck off of the share screen? There you go,
There.
because I want to, the individual, the parent that asked about what can they do with the teachers or school nurses, what I'm showing on the screen here is on the PA Lyme website. We have a section in our brochure section. We have the most recent brochure that's for parents, teachers, and school nurses. So if you are a parent, I would encourage you, you can download the brochure. I would download a couple of copies and share them with your school nurse or any of the teachers that your child has. You can see some of the other school material that we have there. One is a school nurse poster for their office. Another is documentation when a tick gets removed off of a child, and also a questionnaire for if there is a field trip or outdoor activity that's being scheduled. So it's very, very challenging for parents, of course, with young children from what they're going through. But I would probably just like to end it with what you said, Dr. Cameron. I have been involved with the Lyme advocacy for about 15 years now, and situations that I thought would never get better, they do. So there's always hope. There's always the opportunity for improvement. Lowering the pathogenic load, increasing the immune system. You have to just really stay at it. And as a parent, don't give up. I mean, hope is around the corner, so keep doing what you're doing. So, with that, I'd like to thank you again, Dr. Cameron. Very much appreciate your time. And with that, we're going to wrap it up. Remember, for everyone viewing, we do not have a virtual line in December, but we will see everybody again in January. So, thank you very much.
And thank you for having me participate.
All right. Take
Thank
care
you.
now. Thank you.
Bye.